Welcome back to Loud and Clear EMS Guiding Principles, the podcast where we dive deep into high-level education discussions, but connect all of that discussion back to a set of guiding principles so that you never lose sight of what is really important. Today, we're going to break down some emergency medicine research and try to determine how that will or won't affect our real-life street smarts. I'm your host, Ross Orpit. I'm a former paramedic, now emergency physician with a subspecialty in EMS. And joining me today is my co-host, Will Berry.
Hi, I'm Will Berry. I am a flight paramedic here in North Carolina.
Today, we're diving into a study that looks at one of the most iconic tools in our trauma toolkit, the tourniquet. We all know tourniquets save lives, but what happens after we use them? Today's episode is all about the possible hidden costs, the complications that can arise after we apply that life-saving squeeze. We're talking infection, acute kidney injury, compartment syndrome, nerve damage, the stuff that shows up once the bleeding stopped. Joining us again today is Dr. Ben Lee. Ben is a leader in emergency medicine literature review. He is an emergency physician and faculty at Denver Health and CU School of Medicine. He completed a fellowship in clinical research and has a master's in clinical science. And he is a peer reviewer for the journal Annals of Emergency Medicine. Ben recently came on the show to help guide us on best practices when it comes to reviewing medical literature. And today he's going to help us unpack a 2023 paper titled "The Cost of Saving Lives: Complications Arising from Pre-Hospital Tourniquet Use." Not only are we going to review this paper and discuss what implications it has on our practice, but we're going to use the principles from our last episode with Ben to help us do so. This episode is about nuance, risk versus benefit, and using current literature to sharpen your clinical judgment in the field. Before we get into it though, when you're faced with a time-sensitive emergency, such as arterial extravasation from an extremity wound, you need your tourniquet easily accessible in the most logical place possible. But this is not the luxury most of us get when packing our jump bags. We didn't get to design these bags with our specific equipment or mission in mind. So we just put things where they happen to fit, not necessarily where they should be, to increase our efficiency and positively affect patient outcomes. Enter today's sponsor, the Recess Tailor. Their mission is to improve patient outcomes through design. They can help you create a custom bag specifically designed for your equipment and your system so that your gear is exactly where you need it when you need it. If you work with the team at the Recess Tailor, they will help you design a bag specific for you and your equipment from the ground up using the best practices of emergency care design. And then they will send you this prototype to use and reiterate on before you make your final decision, assuring you get the bag working just right for your system. Reach out to them at therecesstailor.com and see how they can help you design better outcomes. All right, let's get into today's episode. Ben, welcome back to the show.
Great to be back. Good to see you guys.
Dr. Lee, I think it's awesome that we talk about this paper because it has kind of a scary title that gives us a premature take-home of the study that I feel was a bit misleading once you dive into the methods and what was actually studied. So I thought it would be a perfect paper not only to talk about and understand, but to also practice some of those things we talked about in our first episode with you.
So before we dive into the paper itself, just remind us, what are our main principles that EMS providers should fall back on when they're reading medical literature?
Definitely, yeah. So there are three main things that I would say. And so the first is kind of what is the quality of the study? How good is it? And some of it is based on the study design. And there's this hierarchy of study design that we talked about. At the very top of the pyramid is your systematic reviews and meta-analyses. And then below that is your randomized controlled trials, kind of the gold standard of study design. And then below that is the cohort study. And that's what this study is. And then the second thing is, how does this generalize and how does this apply to my patients that I see in the pre-hospital setting or in the ED? And then the third thing is this a single study, or kind of where is this in the context of the evidence base for this topic or this question? Do we need to reproduce these results to make sure that they're true or accurate? And those are the three main things.
Awesome. I loved the encouragement from the last episode. Whenever we talk about literature, we always talk about these complicated stats and how they can sometimes mislead us if you don't understand them. But that's like step 5 in reading literature. You can't skip to step 5. And if you try, you'll be overwhelmed. There's no right or wrong way to read literature, but the first step is to pique your curiosity. Be curious about the topic and then read some literature on it. That's step 1, and we can't skip step 1 to go to step 5 because then we'll never read anything. So just be curious and read. Once you start reading regularly, you can start learning about different study designs and then confounders and then stats and over time, and it'll take time to climb your way to step 5.
And I totally agree. Reading medical literature can seem very daunting and it can be challenging and really complicated and dense. But I still don't pick up journals and just read them cover to cover in my free time. I usually will read the titles of the articles. And if that's interesting, I read the abstract. And if that's interesting, I'll read the whole thing, making sure that it's just relevant to practice and figuring out how it applies to the bedside of the pre-hospital setting to the patients in front of you.
Great. So let's dive into this paper. Can you give us a brief overview of this study, why it's important for EMS providers, and what prompted the researchers to look into the complication of tourniquet use?
Yeah, so this is a really interesting study. But even before I get into the study, just a few points that I like to do when I approach an article is to gain context. So think about what's the journal, who are the authors, and kind of what are their affiliations, like what institutions. So this study is in academic emergency medicine, whose impact factor, which is this number calculation based on how many times an article is cited by other journals. This is 3.4, whereas compared to Annals of Emergency Medicine, which has the highest impact factor journal in emergency medicine, is 5.5. And then more context, something like the New England Journal of Medicine has an impact factor of 92. But not every article can be published in the New England Journal or JAMA. And a high impact factor by itself doesn't mean it's a better article. There are a lot of biases that exist in, liking to publish things where there are positive results using certain methods like RCTs, but it just gives you some context when beginning to look at an article. And then these authors are affiliated with the Israeli Defense Forces, and this topic is about tourniquet use. So it's relevant to know that in the context of how it applies to the battlefield and in trauma. And getting to the article and kind of the background, having not practiced in a pre-hospital setting myself, my familiarity with tourniquets is usually when a first responder is wheeling somebody into the ED and they're telling me how long a tourniquet has been up during handoff. So it's definitely a topic that holds relevance for me and I wanted to learn more about. And then reading the background of the study, the authors write that tourniquets have been around since the 1600s, which is astonishing to me and used primarily on the battlefield. And when I looked it up, that's mostly true in that they're referring to the modern tourniquets that have a tightening with a screw mechanism. But the use of just tightening bands or straps around bleeding extremities or those needing amputation was described even further back in 400 BCE by Hippocrates, which is also something I love about literature. It just kind of leads you down these pathways like medical history and stuff like that. And then the authors go on to say that hemorrhage is the leading cause of preventable death in trauma, which anytime something is leading cause of death, it's a big deal. And that tourniquets are an effective intervention to save lives. But now that we know that they work, let's look at the risks of tourniquets and complications like compartment syndrome, ischemia, nerve palsy, so that we can figure out how to prevent those complications.
That's really great background. And I love that little tidbit of the medical history as well. So what kind of study was this? And how does that affect the strength of the findings?
So that's a great question. That brings me to something that we mentioned the last time, which is these checklists, these appraisal checklists that I use very commonly. And so appraisal is just like evaluating an article. And these checklists, we'll use CASP today, which stands for Critical Appraisal Skills Program. They're all free. You can download them online and fill them out as you read articles, but it's just a guide that provides some structured way to appraise articles and tells you what you should be looking for in an organized way. And they're organized by the type of study. So again, this is a retrospective cohort study. So before this, I downloaded one of those checklists and we're going to go through it as we appraise this article.
Yeah, that's awesome. These checklists was not something I was familiar with before our last episode, so something I learned as well. And since learning about them, have loved. They're a great way to learn what's important in an article and how to kind of seek that out or tease that out. So we're going to use this. There's a link in the show notes if you guys want to follow along. So there's two links. One links you to all the checklists for depending on what type of study you're looking at. So there's different checklists for a randomized controlled trial versus a cohort study. And then the second link is the checklist for a cohort study, which is the type of study we're looking at today. What is a cohort study? What is the study design they did for this paper and why we're using this specific checklist?
So for this study, they used a cohort design. And so cohort designs, they can be either retrospective, so they can be looking back in time, or they can be prospective, so starting now and kind of looking forward in time. But they're most useful when looking at a quote unquote rare exposure. So in this case, the exposure would be a wound from trauma that requires a tourniquet. And so it's a very specific indication that is pretty rare in general. And so we want to just try to look at all of these patients that were included, that meet the inclusion criteria, and then move forward in time to see what kind of complications they had. And kind of the more convenient way to do this in an initial study is to do it retrospective. So data that already exists, like in the medical records, go back and look in a certain period of time. In this case, it's 2010 to 2020, and kind of see in all the patients that required tourniquets that were hospitalized, what complications did they develop in that span of time.
And when we talk about certainty of evidence, one of the big things we look at is, one, how well was the study designed? How well was the study done? And we'll talk a little bit about that as we move through this. And two, was that hierarchy that you mentioned earlier. Remind me where the cohort study falls in that hierarchy and how that kind of affects our certainty with regards to their findings.
Yeah, again, this is a cohort study. So this falls kind of like in the middle to top of the hierarchy. So below randomized controlled trials, this is kind of the next best design. So if you're just judging it on that criteria, it's good. But again, there are many different factors that determine kind of what study design that you're going to do. And I think this is for this type of question, it was very appropriate.
One question I have, and maybe this is skipping ahead slightly, is this verbiage of requires a tourniquet. So as a pre-hospital provider, someone that's been there when these tourniquets are applied, as they've become more ubiquitous and people are more comfortable with them, I think they're applied more frequently. And whether the wound actually required one or not, that's a little bit subjective. So did they account for that, and did they define that at all?
So that's a great question about indication. And in this paper, they don't really address that directly. But what I would say, reading between the lines, is that it is a little bit subjective as to the quote unquote necessity of tourniquets, because all that they were doing, again, this is retrospective, so they could only collect the data that existed, were patients who had a tourniquet when they arrived to the hospital that had been applied in the pre-hospital setting that were then admitted to the hospital. So I think there's a lot of probably subjectivity as far as who got the tourniquet and who did not get the tourniquet for this.
And that kind of flows real well into our first question on this checklist. And so this checklist, as we go through it, it's broken into three sections. The first section is A, are the results valid? The second section is B, what are the results? And the third section is C, will the results help locally? So we're going to follow through these sections in each of the questions in each of them. So in section A, the first question is, did the study address a clearly focused issue?
Yep. So for each of these checklist items, you can answer yes, no, or can't tell. Then you can kind of fill in a little narrative thing. So for this study, based on what we know now, I'd say yes. But if you're not sure, the checklists offer specific things to consider. So for this question, it's is the question focused in terms of the population studied, the risk factor studied, and is it clear whether the study tried to detect a beneficial or harmful effect? And was it clear the outcomes that were considered? So I would say that as far as this goes, the population is pretty clear in being all casualties with a tourniquet in the pre-hospital setting, subsequently hospitalized. And the risk factors that they described in the study, that seemed pretty clear as well, being all the factors around tourniquet application. And the study is clearly trying to detect complications or harmful effects. And then the outcomes are detailed as well in the paper. So I think that they do address a clearly focused issue.
Great. So following that was the cohort recruited in an acceptable way? How were patients selected and what were the inclusion criteria?
So in this, the things that they list to consider are look for selection bias, which might compromise the generalizability of the findings. Was the cohort representative of the defined population? Was there something special about the cohort? Was everybody that should have been included in the study? So the question is getting at something kind of conceptual about research, which is, research is trying to find the true objective answer if it exists about a population, but it's impossible to study every single person in the population. So what you're trying to do is find a representative sample of people that can give you an answer that you can then generalize to the entire population. But this process of doing that is really fraught with bias, including this thing called selection bias, which is a type of error when your participants or subjects in your study do not match the population you're intending to study. So for this study, they're looking at tourniquet complications. Their inclusion are adults, and so people that are greater than 18 that are hospitalized after pre-hospital tourniquet application, which is pretty inclusive for their question. This is a single center study. It's at a level 1 trauma center in Israel, which is the largest medical center in the country. So while it's not inclusive of all trauma centers and probably tourniquet use in the entire country or the world, it's a pretty good place to start. Who are they excluding is another good question to ask next, which is it's pediatric patients, those who died before or upon arrival to the hospital, those discharged directly from the ED, so who were not hospitalized, and those who didn't have documentation of tourniquet times. So that immediately leads me to think when I'm later going to interpret the results, there's a good chance I won't be able to apply the results to kids or those who are discharged from the ED, but overall think the inclusion should help them answer their question in a meaningful way. That could then lead to further studies on this population or in pediatrics or those discharged from the ED. And some of these methods that they use are not necessarily their choice. A lot of research is based on kind of the data source that they're using. So in this, it's the Israel National Trauma Registry, which has been looking at it really similar to our National Trauma Registry, which only contains data on people who are hospitalized, so not discharged from the ED. So that adds some restriction in the analysis and restricts the generalizability a little bit. But maybe this is the best source of data available, and doing a larger study might not be feasible at this time. So you do your best with the data that you have.
If it only includes patients that were hospitalized, there's potentially a lot of confounding injuries with those patients as well. Is that correct?
Most definitely. Yep. And so you might think off the bat that, well, I mean, they're all hospitalized, so maybe they're a sicker cohort of patients than the general population that needs tourniquets, because I don't know what proportion of people who have tourniquets up pre-hospital get discharged from the ED, but it's something important to consider. And some people would say that's confounding by indication, and that, like, those who have more severe injuries might require tourniquets for longer in some other type of way that would then lead them to be hospitalized, lead them to have more complications. So it's something to be cognizant of when you are interpreting the use results and then trying to bring them to the bedside or the pre-hospital setting for sure.
Yeah, and one of the other things they mentioned in their discussion, I'm not familiar with exactly what the previously reported rate of complications are, but they stated that their found complication rate was slightly higher than the previously reported complication rate. I don't know if that is because of this confounding by indication, if those other studies included discharged patients, or another confounding by indication is the type of injuries that we're seeing here. A fair amount of these injuries were traumatic amputations that required tourniquet placement, which, in my own practice, practice, like I think in this study, correct me if I'm wrong, it was maybe like half the patients were traumatic amputations, whereas in my own practice, I find that that's actually a more rare reason for why I'm using a tourniquet or seeing it used pre-hospitally.
Right, right. Yeah, I think that's all very true and good points. We had talked about selection bias before, and that may play into this a little bit, but I think it's like, what question are they trying to answer in this? And the question is specifically about people who are hospitalized. So it's like they understand that this is not like the broad population that needs tourniquets. I think off the bat, they know that they're hospitalized already. They're probably sicker. So they knew that they're looking at only those patients. So if they were trying to extrapolate and say, oh, we're drawing conclusions about all tourniquet use and then only looked at hospitalized patients, I think that would be a really good example of selection bias. But for this, I think that for the question that they're trying to answer, which is pretty specific, they're doing a decent job about their inclusion and exclusion.
This is somewhat tangential, but what you just said makes me think about it. Where is the line? So sometimes I feel like you probably have to design your question around what information or data is available to you. You know, like to take an extreme example, we're talking about tourniquets, emergency departments, and patients hospitalized. So we can't ask a question about like their diabetes management or something, right? So like we can only ask certain questions of that information. But at what point are you getting into maybe area where you're doing poor research, where you're curtailing your question so specifically to what's available, or is that not a problem?
Yeah, no, it brings up a really good point. And I think that, yes, that's true that people will kind of only look at like conveniently the data that they have in front of them. But I think that it's good when you're trying to figure out a research topic or question. It's to start broad during your time trying to, do some preliminary literature review, and then thinking about what type of data sources you have available to you. You'll have to maybe narrow that question. So you really have to be, again, aware of how data can restrict you in some type of ways and what conclusions you can draw from the data that you have. But I would say, from the very beginning, start broad, ask big questions, and then start to narrow from there.
Great. As we continue to move down this checklist, the next question is, was the exposure and outcome accurately measured to minimize bias?
So this question says, consider measurement, classification bias. Did they use subjective or objective measurements? Do the measurements they use actually reflect what you want them to? And so just quick review, measurement bias is when there's a flaw in data measurement. So for example, if tourniquet application times were measured inaccurately for some type of reason, clocks were wrong or something like that. Classification bias is where something is misclassified. So in this study, they classify tourniquet complications by severity according to this Clavian-Dindo scale, and which is used in the surgery world to classify kind of post-op complications. So as far as we know in reading the methods, they use many objective measures and well-known classification schemes. For the most part, I think that one big point is kind of going back to what was the necessity or requirement of tourniquet application, which is hard to tell from this study, but is probably somewhat subjective by the provider in the field. And another thing they do well is describe how this trauma registry is operated. So they have these trained registrars supervised by trauma directors that ensure accuracy and completeness of data. So that's really good. That's systematic. While in the case, if it was just like a single person who is doing it on their own, it just might not be as reliable. And they also say that the primary author, who is a clinician, performed the chart reviews individually to assess for complications. So that's pretty good as in comparison to somebody who just doesn't have as much medical knowledge or experience.
Great. Do you think the authors identified all important confounding factors, and have they taken into account of the factors in the design and or analysis?
Yeah, this is a really good question and a big topic, but confounding on a basic level is when there is something, some variable that distorts the relationship between an exposure and an outcome. So, a classic and very old example of this is when looking at people who drink a lot of coffee, like myself, they found higher rates of lung cancer without realizing that coffee drinkers back in the day also smoked more. So that distorts that relationship. So in this, when I was reading it, I thought, oh, one potential compounder could be confounding by indication. So like, was there some indication that led to a difference in treatment? Like, did the worst types or appearing of exsanguinating extremity injuries lead to providers to apply tourniquets longer than necessary, which led to more complications? So there are statistical ways to control for confounders. The problem is a lot of the time you don't even know what confounders exist before conducting the study. But for the most part, I think that they did a decent job here.
Was the follow-up of the subjects complete enough or long enough?
Again, we're just talking about hospitalized patients here. So there's this really robust system with their trauma registry, which tracks tourniquet use and the complications while they're hospitalized. So I would imagine that the follow-up is pretty complete with the data that they have. But as we talked about before, we're not talking about patients that are discharged from the ED, and also are not talking about patients who might be hospitalized and then discharged, but then might develop complications later. So there could be some issues we're missing, but for the most part, follow-up, as far as we know, is complete. Being a retrospective study, one of the other things they say to consider is people dropping out, but this is a little bit less of a concern being retrospective as opposed to like people getting a new medication that they then develop side effects and then kind of decide to drop out of the study after that. So a little bit less of a concern. And then just to pause here. So we've kind of gone through the method section of this checklist. So looking back, the methods are, I think, the most important part of the study and the paper. So because the methods are not sound or high quality, then it's like you're going to have a hard time believing the results. So looking back here, I think that in regards to the methods, they've done a pretty good job. And so it makes me feel like they've tried pretty hard to use high quality methods to answer their question, and we can kind of move forward into the rest of the paper and the results.
Great. So yeah, that kind of completes that section A, are the results valid? And just like you alluded to, a big factor of if the results are valid are how well did we do this study? How well are those methods described? And do we feel like those are the appropriate methods to use? And so now we're moving into section B. What are the results? And so what are the results of this study? What were the main types of complications they observed from pre-hospital tourniquet use?
Yeah, there's a lot to unpack here, but let's just get to it. So they did a nice job of demonstrating the inclusion with a flow chart, which a lot of papers do, showing that there were, to begin, 138 casualties at their medical center with a pre-hospital tourniquet and were hospitalized between 2010 and 2020. So 138. And then further down, 14 were excluded because they were too young, they were deceased upon arrival, or they didn't have tourniquet time documented, leaving the study with 84 subjects, of which they found 20 had complications. So about 24%, or almost a quarter, 1 in 4 patients, which is a pretty high proportion. But again, these are probably a sicker cohort of patients because they're all hospitalized. So if you took into account those who were discharged from the ED directly, the rate would probably be less. And then table 1, you always hear about table 1. So it's an important place to look at when you're reading a paper. It usually lists all the variables that they looked at in the study, like demographics and the mechanism of injury, kind of wound contamination in this case, and then compares them between groups. So in this case, those with complications and those without complications, and then does an analysis and gives you a result like a p-value to see if there is some significance in the difference between the two groups. And so the reason this is important is because if there's imbalance between the characteristics of the groups, then this could give you an idea there's some confounding bias. And so in this study, they found a few interesting things up front in this table 1, which are that blunt object mechanisms were more likely to have complications compared with sharp penetrating injuries, and then that contaminated wounds were much more likely to have complications compared with clean wounds. And they also found that a low hemoglobin on hospital presentation was associated with more complications. And then a little bit further on, they found that the indication for a tourniquet was different between the groups, with it being more common in traumatic amputations and kind of multiple injuries in the same limb to have complications, versus the indication for massive hemorrhage had fewer complications. So these findings, when you hear about them, may not be super surprising in that, sure, blunt object strikes might lead to less clean or straightforward wounds to tourniquet, and dirtier wounds are probably worse, and lower hemoglobin means you probably lost more blood and might have a harder time recovering in the hospital. But seeing actual data and numbers can back up anecdotes and feelings in a way that can be pretty powerful. So what's also important to note in the results is what is not different between the groups in the results. And so the duration of tourniquet application, which is overall 44 minutes, the effective application of the tourniquet, the demographics like age and sex, the type of evacuation platform, there were no differences there. So leading one to believe that it's not really how long a tourniquet is applied that leads to complications. It's not the age or the sex or the type of transportation. It's potentially those other variables that we talked about, like the mechanism and contamination.
Before we get to the complications, you just mentioned something there, that there was no difference in the time of tourniquet application and the likelihood of complications. I feel like that's fairly surprising to me. What do you think of that?
Yeah, that's a good question as well. So I'm not super familiar with all the tourniquet pre-hospital literature, but what they describe in the discussion is that 44 minutes overall, which they showed in this study, is a pretty short amount of time. And so 2 hours has been shown in previous literature to kind of be a threshold for where you might be seeing way more complications after that. So this is a overall pretty short duration of time between both groups. So there was no difference. So both of them were around 40 minutes. So, one might think that with a longer application that you would see more complications like compartment syndrome and ischemia and nerve palsies. And that's probably true, but that might be seen when you hit closer to the 2 hour mark. And this study, it was so narrow, around like 40 minutes or so, that we probably didn't see that many patients who were going on to develop those types of complications. So again, this study wasn't specifically trying to look at that time difference. It was one of the things that they were looking at, but in general, it's interesting. But taking in the context that it was a short duration of time, I think that's some just context to add when interpreting these results as well.
So given that the overall duration for all the participants in this study was fairly short, we may just not have had enough of that time piece to see that difference that we fear. And that goes along with the type of complications they saw. Like you said, they didn't see many nerve injuries. They didn't see many compartment syndromes, which are the things we really do start to worry about greater than 2 hours, which I don't know if anybody in this study had a tourniquet up for longer than that.
Yeah, that's a great point. So furthermore, about the complications, so they saw the most common complications were local infections. So they saw 9 cases of that, which was 11% of all casualties. And again, there were 20 cases of complications, so it's about half of the overall complications. Compartment syndrome was in 4% of all casualties. Thromboembolic events was in 2% of all casualties. And then they had 1 case of rhabdo. And then about 2/3 of the complications were categorized as happening early, so in the first hours to days, and then 1/3 were later. So that could lead you to believe that you'll see more complications earlier after tourniquet application. And then the vast majority of these complications, 85%, were rated on this Clavien-Dindo scale as 1, which is the lowest severity and requires just kind of basic treatment. Again, getting back to our point about tourniquet duration was much shorter. So if it were longer, maybe we would see more severe complications on this Clavien-Dindo scale that required, fasciotomy from compartment syndrome and things like that. Lastly, in the results, all of those things were done by what we call bivariate analysis. So you're looking at one specific variable, so mechanism of injury, and then comparing the groups. You're not taking everything into context at once, but it's useful in just trying to see, what are these interesting relationships and things to look for when you look at the next thing, the multivariable analysis, or which they did with multivariable logistic regression. So this looks at multiple variables at the same time, and it adjusts for the interplay and the influence of the variables on each other and potential confounders, like did the mechanism of injury influence how contaminated a wound was, and how did their age play into this, their complications, and it kind of sorts through all these predictors and adjusts for their relationship. And then it gives you kind of the most accurate associations and results when you're taking everything in the context and not just looking at single things. And so in this case, they only found two variables that were associated with complications, and they were the hospital length of stay and injuries due to a fall, and not the injury type. So not like blunt injuries or penetrating, not contamination level, not the indication for tourniquet use, not the hemoglobin level, which is all really interesting.
Yeah, that is really interesting, because when you initially talking about that 100% of the complications occurred in contaminated wounds, which you're like, whoa, that's a big factor. But then when you do this multivariate analysis, you're like, well, maybe that was just confounded by something else.
Exactly. So that, I mean, we're not going to go into kind of the statistical methods too much because I don't want your listeners to fall asleep. But just to say that is the value of multivariable logistic regression, is that it just takes everything into context of each other and really gives you a more accurate overall representation of, in this case, complications and what causes complications.
This question probably oversimplifies some things, but maybe go with me on it for a second. So when I think about patients, I'm trying to kind of visualize this cohort of patients, and there's just so many injury patterns that they could have in addition to requiring a tourniquet. And then as I listen to you, I'm hearing about some really advanced statistical analysis and modeling that's happening. At what point do you kind of take a step back and say, okay, well, our math is showing correlation, but are we really like establishing some sort of causation?
Yeah, and so causation is, I think, what everybody wants to be able to quote unquote prove, but that is typically reliant on the study design. And so randomized controlled trials, for example, in this type of retrospective cohort study, we can only really look at how things are associated with one another. And the more that they're associated gives us an idea of, oh, maybe there may be some causation there, but it can't truly tell us that one thing causes another. But again, given resources and kind of like your data source, it may be the best that you can do and can still be valuable in giving you some preliminary results that may be able to lead to an RCT in the future and give you kind of more causative inference, as we say. And then I guess like just going to the next question on this is how precise are the results? And just because we talked about some of that already, it's asking to consider like things like confidence intervals. Quick refresher. So p-values, which they use in the bivariate analysis, is telling you how likely your result is due to random chance. So the lower the p-value, the less likely it's just due to chance or luck. And we usually say 0.05 or 5% is kind of the threshold. So the lower the p-value, the more likely it's not random, and the more likely there's some true association there. And then a confidence interval, usually we use 95% for that, tells you how confident you can be that true result lies within that range, that confidence interval. So for example, in this, the mechanism of falls, that was found to be associated with more complications. Like one of only two variables that they found was truly associated with more complications. So that while significant with a p-value of 0.045, the confidence interval that they found was really wide. So it was 1 to 98. That's a huge confidence interval. And whenever I see a wide confidence interval, I have some skepticism. And so it's like, how do I interpret this? And again, how do I bring this to the bedside clinically? So these are all things that you have to consider. So conversely, the confidence interval for the length of stay, which is the other thing that they found was associated with complications was really narrow. It was 1 to 1.2. So that gives you much more confidence that the true value lies within that very narrow range.
So taking that into account and the bivariate analysis, the multivariate analysis that has given us different answers, do you believe these results? What's kind of your take home after discussing all of that with regards to these results?
Yeah, good question. So given the study population and the design of this study, I think yes, I believe the results. I think they used good methods and did their best to answer their specific question. In the discussion, one thing I don't agree with them is talking about how complications were associated with things like wound contamination, because again, while true in the bivariate analysis, that's really only in isolation, not taking into account all the other variables. So it didn't hold true in the multivariable analysis. So I wouldn't really say the same thing in the discussion that yes, there's this true association. I would spend more time talking about why those bivariate analysis results were no longer significant after the multivariable analysis, which shows that there's like some other underlying driver, and it's not wound contamination or the mechanism that led to complications. And perhaps those with more contaminated wounds had more blunt trauma and longer hospital length of stays. And it was not the contamination that led to the complication. So again, I believe the results. I think that they did a nice job in asking a very specific question. But again, if you want to generalize that more broadly, you have to take into account like what were they looking for and what was the specific question that they were asking.
If you were to summarize these results or your take homes from this paper, what would you say?
I would say the most interesting and surprising thing to me, not knowing much about this literature base, was the high rate of complications, even in the context of a very short duration of having a tourniquet up, again, 44 minutes, and they still saw almost 1 in 4 people develop some complication. And while the complications, again, on this scale were not very severe, it's still something to consider when you are in a pre-hospital setting, you're putting up a tourniquet for some indication, just understanding that a lot of these people, especially those that are going to get hospitalized, may have some kind of complication. And is there anything I can do to prevent it? And again, the bivariate analysis did not bear out in the multivariable, in that contamination and the mechanism did not have a true association, but there are limitations to the study. Maybe there'll be another study down the line that'll be larger, more multi-centered, international, that will include patients that are discharged in the ED, pediatric patients, more inclusive and representative of the overall patient base that needs tourniquets. Maybe in that study, they do find that contamination leads to more complications down the line. So it's just something to consider in looking at all the results and saying, hey, these are things to consider when we're treating somebody in front of us in the pre-hospital setting.
I know this is kind of mixing a couple things, but some EMS agencies are advocating for early antibiotics. Do you think there's any evidence here to support that, say it's good practice, or no, hard to tell?
I mean, it's a good question. Again, the most common complication in this was local infection. And again, a lot of these complications had some contamination, well, all of them really. So this is my opinion, but we know in like the sepsis literature and those things, how important early antibiotics are. And so, yeah, I think that one could try to extrapolate a lot of these different studies and say, hey, maybe in a certain subset of patients, maybe who have super contaminated wounds, maybe we should be giving them early antibiotics. But it's a great idea for a study. I don't know if it's been done before, but there's probably some reason that people are starting to think about this in a practical setting.
Yeah, you're absolutely right. That's a good question to ask next is, can we prevent some of these complications either from doing good pre-hospital wound care, irrigation, cleaning the wounds, or with pre-hospital antibiotics, if those things will have a benefit at all? Because we want to make sure that we're focusing on truly impactful things, right? We're talking about these complications, and I feel like these complications may be scary to people, but at the end of the day, you're applying this because you're worried somebody is about to have life-threatening blood loss or has had life-threatening blood loss, and life and limb come far above these complications. So we don't need to hesitate to put this tourniquet on. We just need this to inform us about the risks that occur after we put the tourniquet on so that we can be prepared for them or ask these questions and find ways to maybe prevent them in the future.
For sure.
One thing that this discussion makes me think about is the need for pre-hospital providers to be involved in research, because this study was designed with, a study that discusses tourniquets has a lot of profound impact on EMS care. We're usually the ones putting these tourniquets on. But this research started when the patient hit the emergency department door. And so I think for anybody out there that's interested in research, pursue it, run with it, because I think this study is a good example of how the information we could gather in the field could only further inform what we learn.
Yes, that's a great and a huge point. And I think in general in research, we are getting better at incorporating the people who the research most affects early on in the study, not just saying, hey, we did this study about your setting and now you have to apply it. It's, hey, let's get the EMS providers in the room when we're trying to figure out what the study question is, what the study design is going to be, because they're content experts. And that expertise is really valuable from the very beginning of the study to the very end. And it just, like you said, Roz, it just makes it much more meaningful.
Yeah, so as we wrap this up, and we've alluded to this a little bit, the final section is, will the results help locally? In other words, what are the implications for my EMS practice after reading this study?
Yep, this is about generalizability. And so taking these study results and applying them to your patients is always the most important question about medical literature. I mean, it's a great question that I would ask you guys. How does this apply to sick, hemorrhaging patient in front of you? Does it change your practice? Does it reinforce it? Does it inform it in some type of way, or does it like pique your interest in trying to learn more and get involved in research or something like that?
For me, I think it informs the care. I think Ross hit on a key piece, which is we're putting this tourniquet on because we're worried about life or limb, and that care is incredibly important. That's paramount. We're thinking they're going to bleed to death, so we need to put this tourniquet on. I think the very first most practical thing it makes me think about is passing along to the emergency department staff how contaminated the wound could be, or what I saw, or anything that existed in the field that would help inform some of the decisions that about the further steps in their care. But it's not going to necessarily impact my decision whether or not to apply a tourniquet.
Yeah, I agree. I think, just as I said before, you should continue to apply tourniquets if they're needed, or if you're worried they're needed. You should have a low threshold to do it because they are truly life-saving. These patients were all admitted to the hospital, so had a high likelihood that they needed this tourniquet. And we didn't even look at the complication rates for patients who were discharged, which I'm going to assume is probably pretty low. And so if you think they may need it, I would apply it. I think this piques my interest about, are there other things we can do? Are those other things worth my time and focus? And I think we need to answer that. But for now, it's about saving their life or their limb. And so finally, to round this out, I do think that one of the final questions is, do the results of this study fit with other available evidence? And I think they do. They did show a slightly higher complication rate, and we talked about why that may be, but mostly this was a descriptive study of like, what are the complications that occur after a tourniquet is placed? And so I think it informs the admitting team's care a lot about the complications they need to be ready to address if they do occur and they need to be looking out for. And I think we know that complications can occur from tourniquets from other prior studies, but we also know, as we've just said time and time again, that they are life-saving and we should use them and not be afraid to use them if we're worried. So Ben, can you just take us home, wrap this up, summarize this for us?
I really liked your take-home point about just, the importance of tourniquets in general and the clinical application, because that is the number one priority, is to stop the bleeding. To go back to some of the take-home points about research We talked about how good was the study, what was the quality in the hierarchy of evidence. And again, this was kind of in the middle to higher area. But I think that this doesn't take away from the study necessarily. It just leads to more questions and further studies to improve the evidence. And then the kind of second point was, does this apply to my practice environment? That's a question that you're going to have to ask yourself based on the patients that you see in the pre-hospital setting or in the ED, based on, again, this specific study. And take home point number 3 is this a single study? Are there more studies that need to be done to show the same results? And the answer to that is most definitely yes. These results definitely need to be reproduced, and the study population needs to be expanded so that we can take these things and apply them to all the patients who you might see in the pre-hospital setting who are exsanguinating.
Big thanks to Dr. Ben Lee for helping us break down this study. So, tourniquets are still a critical life-saving intervention, and complications, while real, are relatively rare and often manageable. But just like any tool, it's not just if we use it, it's how we use it. Proper placement, good documentation, and transitioning care quickly all make a difference. If you found this episode helpful, do us a favor, share it with your crew, leave a review, and hit that subscribe button so you never miss a new episode. Follow us on Instagram at EMS Loud and Clear, and check out our website at emspodcast.com, where you can find blog posts and bonus materials for most of the episodes. Until next time, stay safe, stay sharp, and remember, evidence-based care starts in the streets.